Hey everyone, this is the Nips and Sips podcast. Feature me, I'm Dr. Jeremy Boyd, and my partner in crime over there, Dr. Brandon Cruz. Today we're going to talk about something that a viewer or listener brought up to us, kind of about the history of manual therapy. I guess you can say the different tribes or led by different leaders, such as Paris, Cattleborn, Maitland, and a couple others. We're going to go into like soft tissue and some manual therapy or manipulative therapy. I feel like this one will probably take a couple episodes, maybe a two-part series, but we'll kind of go into different styles and take it from there. But before I get into it too much, Brandon, how's it going?
Going well, Jared. Thanks for the intro. Yes, this is a great topic, if especially if you're a bit of a geek like we are. I guess my background, and I got to reach out to him. Probably one of the smartest men I've interacted with. The ran my fellowship program at Regis, Cam McDonald. Uh, Basically, in a nutshell, we were in a fellowship weekend talking. I had asked a question. We were kind of having just a kind of roundtable discussion. Myself and a couple people it kind of just came about manual therapy and the history of physical therapy in general. And he literally just went down a rabbit hole from why we are where we're at as a profession. Talking about the restrictions we have, direct access, or the limitations each state has, payment throughout the nation, why we're not respected, and to kind of explain why we're where we're at. He went down the history, and my jaw dropped. It was about a 45 to an hour long, just him going off the top of his dome about the history of manual therapy. And this is irrespective of joint based manipulations, mobilization, soft tissue, dry needling. Like, this just went back hundreds of years, all the way up to basically present day. And like I said, I need to reach out to him and see if he'll do a podcast with us. I don't know if we want him talking about this topic now that we're doing about two episodes of it coming up. But I mean, that guy's awesome. I think he's been on AOMP's podcast as well, talking about some various stuff. I think he was on a health education transformation podcast. But the guy's definitely a mover and a shaker in the field. I will do my best to pass on some of the knowledge that he has passed on to me, some of the wisdom that he has. So I do apologize now if I misquote him, and if I'm not going to do as good of a job. I'll tell you that right now, but we'll do our best. And just prepping for this show, looking at it, I mean, there's a lot of detail in here, guys. Probably why we're going to be extending it to two episodes at least, just to try and get everything in there. But enough on that, as I already ranted, and we're not even 5 minutes into the show. Let me talk about my
All right.
drink, and then I'll pass it off to Jeremy. I have the Balvenie, I should say, Scotch whiskey. It's actually a little light because we've been sitting here talking, Jeremy and I. This is a 12-year aged in two barrels. I actually have the bottle here. This was a gift from my buddy Eugene from PT school. He has actually his own practice as well. You've met him, I think, one or two times, Jeremy.
Mhm.
So the first casket, it's maturated in or stored in, is a traditional whiskey, has whiskey oak, vanilla spice, things like that. The second barrel or cask, it's stored in, is more of a fruity, kind of a little bit of honey taste, single malt there. So that's what I have today on the rocks. Did I say this was a birthday gift? Anyway,
Yeah.
I'm losing track already. So yeah, this was my 31st birthday, a couple weeks old. I'm now home. I'm trying to, if you listen to our last podcast, trying to switch it up a little bit, so I'm not always staying with it.
There we
Jared,
go.
I will say thank you to the bourbon you got me. Very nice bottle, pristine there. Was going to crack it open, and I was like, I can't yet. Not to say our show isn't worth it, but I feel like you need to be there to take in part, actually,
There we
side
go.
by side and not virtually. So I do want to save that for you. It's a very nice bottle. I will keep the suspense there and not mention what you got me for the audience, but they will get their turn to hear about it.
There we go.
So what do you
Next
got,
celebration. So this deck, I guess, did come from you. Is that little that winter pack series that we got at the Christmas collaborative Trifecta Pursuit Party?
White Christmas.
Yeah. So this might be. I think there's one more. There's a chocolate stout. It didn't seem like it was cold enough for that today, so I went with this one, which also is. This is a Kentucky Vanilla Barrel Cream Ale, which was aged in bourbon barrels, so we're on the same page here.
There it is.
Obviously not tested this puppy out yet, but I'm looking forward to it. And then, does Cam drink?
Yeah, of course he does. So Cam was me and Jeremy harassed him.
Cheers.
Quick story about Cam.
This was fun.
We harassed him to our last AM conference. It was down in Florida last October. So me and Jeremy went down a day early to golf. It's our new hobby now. And the last day of the conference is really only half a day. So Jeremy and I took late flights. We skipped the morning session of the conference, and we're golfing again. So we asked Kyle to play with us. So Kyle was down. And last minute, I asked Cam. I was like, "You want to play with us?" Not knowing Cam has a pretty good golf history. But Cam's like, "All right, let me see what I can do." He's like, "I'm very busy. You should ask me sooner." Yada, yada. We're in the middle of like finishing up the day of a conference, and he was supposed to have a meeting at night. Lo and behold, he makes the meeting he was supposed to have basically right there in the conference bar room, gets what he needs to get done. He called me over for some reason. And I was like, basically like, "What do you want?" And he's like, "You want me to play golf with you tomorrow? Answer my question." So I don't know. I helped him out, whatever he needed. And then he got to play golf. Mid-round, I found out he was like a junior Olympic golf stud. Probably hadn't picked up a club in years and was still wiping the floor with you, me, and Kyle.
Kick their ass.
It was fun to go out and play with him.
Yeah. Well, we tied. Didn't we tie?
I have to reach out to him and get him on here now. We've talked about it.
Yeah, exactly. If he can get on here and enlighten us, and he's one of the top clinicians out there, and I respect him highly. And he didn't even talk too much PT when we were out golfing, but he blew my mind. So you can just be around certain clinicians, you can tell who knows their stuff and everything like that. But back to my beer, Jeremy Boyd rating. This is really good. I'm not a big vanilla-y type of person, but this was good. I mean, definitely hit your nose with it. Kind of vanilla toffee style, but I'm going to give this for a cream ale, which I don't usually go for. I'm going to give this an 8.1. That's pretty good. So thank you there, Brandon.
No problem. And I said White Christmas. Chinese Christmas?
White elephant?
White elephant. That's
what it is.
I confuse names all the time. Forgive me.
Yeah.
But yeah, that one.
It's the cup here.
So all right, let's dive in. I guess and I know Jeremy typically says fast forward the past 5 minutes or whatever mumbo jumbo that we talk about. And if you're now at, I don't know, whatever minute this is, I do advise you just to listen to the beginning, because you may feel like this podcast is a bit incomplete if you didn't kind of hear some of the stuff we talked about at the beginning. But with that, Jeremy, what was the question? I don't know if you want to name the individual, leave him anonymous. But this kind of is what spurred it, and then it kind of grew tentacles when Jeremy and I were preparing for the podcast.
So I'll just go first name basis. Jimmy, one of our listeners, he said, "Boy, I really enjoy the podcast." So thank you. We got a follow-up question on our butt massage one, by the way. I have to fill you in on that, but do you think you can do a small discussion regarding go-to literature or authors for specific topics, i.e. Paris Mulligan for manual therapy, Yanda or Chateau for METs, just thinking for literature to bolster clinical understanding. So, we figure we can get into some of the research, and then a lot of people just don't know what type is what. They're taught some manual therapy, don't know really the background to a lot of it. That includes myself personally. I was just taking what my CI taught me and I just applied it. And didn't really, I know it was a lot Maitland at first, but it was probably a blend of a lot of things. So kind of diving into where it all came from and where it all is now is important. And we're going to talk about a lot of different styles of manual therapy and go into like the forefathers of them and such and so forth. But that was cool. I did a little research myself beforehand, as they all had a similar theme of, yes, they had their own technique and a lot of them named them after themselves or whatever it may be. Kudos to them. We got to create the Cruz Boyd, some fancy name or something like that. Manual
We
therapy.
already have the
sort of
cuboid that we're
cuboid. We have the Cruz crack. So, but it was cool to see even some of these techniques which were created, hundreds. We're going now hundreds of years, and going all the way back to Hippocrates and those sort of things. Is they did these techniques and then they got their clients moving. A lot of obviously manual therapy is bashed that just assume that all you do is manual therapy, but even way back it was an adjunctive to movement. But yeah, so that was a question
awesome
about that. So thank you, Jimmy, for stirring this up, and I'm looking forward to this 2-part series probably.
Yeah, Jimmy, great question. I guess in short, just to kind of answer that first part about the research, I wouldn't say, Yonda and Mulligan and, some of these people, Syriacs and stuff, some of these people are dead. So, I mean, they're not doing research per se, but if you follow like JOSPT, I would say JMMT. Those are, that's the Journal of Manipulative Manual Therapy. There are a couple other ones that are putting out good research. Typically, the main authors that study manual therapy are really its effects. At least right now, are the Childs, the Tim Flynn's, the Clelands, Whitman, Puentedura, Adrian Lowe, Cam McDonald's. I mean, I'm probably Scott Burns. I'm missing some stuff there. I know I am, not to slide anybody, but that's what they're looking at in terms of what are the effects. And typically, yes, it's manipulation and mobilization, but that's not to say that you can't do a Mulligan mobilization with movement with that. So I would say, trying to research, the topic, and I'm sure you could type in. There's case studies which sometimes are good to get insight of a technique or a method somebody's doing. So I would say start there. After you kind of master that and understand how you're treating, I've taken AOMP tends to be, my go-to, or even IFOMT. I mean, you're amongst the top of the top. And I have a PowerPoint here. This one was by Paul Minkin. I forget what year. This was Salt Lake City. So 2017, basically. This one's awesome. It's called "The Manual Therapy World is No Longer Flat." We used to think as clinicians, and unfortunately some clinicians out there, especially these social media gurus, tend to think that manual therapy is in isolation, and that's all we do. And yeah, while our approach which was once very biomechanical in nature, has evolved to a multi-specific approach, neurophysiological, biochemical, even placebo and things like that. So I'll leave it at that. And with that, we have to understand where we were. And I think probably where most of this conversation is going to be is kind of the history of manual therapy, and then we'll move forward there. But Jeremy, I saw you had some that lovely article talking about the history. If you could kick us off with that. Jim, I hope I answered your question, or at least part of it, and then we can continue on going from there.
Yeah, so this is a good article for pretty much this whole topic that we're going to be having. It's manual therapy, the historical, current, and future role in treatment and pain. It was in the Scientific World Journal. It was actually all the way in 2007, but we're seeing similar themes. 2007. It's like, yeah, it was 2007. And I'm like, damn, that was 13 years ago. Shit.
Getting up
But
there.
so, Russell Smith, who's in the Department of AT and Physical Therapy, University of North Florida. Where's my highlights? Okay, yeah. So this one, it was cool. He went to like just like all the way back into the history of when it all happened. I was talking about Hippocrates and those sort of things. I think there's some mentioning of like Hippocrates used to do a technique off of a ladder, had to like people with like back issues inverted off of a ladder. Doing some, I guess, various of thrust or manual techniques. So that's going all the way back, 5th century BC, as stated in here. And it kind of goes into, in the 2nd century, different doctors or physicians at the times, and what they did. And then went to the history of like bone setters. And 19th century, we're talking about, Dr. Andrew Taylor Still and David Palmer and the osteopathic and chiropractic ages and those sort of things. And then starts talking about, physical therapy and how we were kind of educated by Manel and Syriacs. But is kind of going into the purpose of why we're doing things where we are. And again, even in 2007, it kind of highlights certain things of, spinal manipulation is effective for especially people with acute low back pain. It even brings up the Tim Flynn study of the treatment-based classification, and the CPR for a lumbar manipulation. It goes into things about cervicogenic headaches. Even goes all the way into like ankle sprains and peripheral manipulations, and just highlighting what's effective and what doesn't seem to be effective at that current time. So really good article starting to just talk about first mostly joint manipulation or mobilizations. It even goes into massage therapy. So most of what it's indicated for could be delayed onset muscle soreness. A lot of people throw massage under the bus. Do I do a ton of massage? No. Or soft tissue techniques, not as much as I used to. Like, will I use it if someone, especially a high-level athlete, sore and I feel like their treatment's not going to be effective because they are too sore, or that positive psychological effect of decreasing anxiety and stress? Some people just need a little TLC. I do have that in my toolbox. I don't throw it under the bus just because it's, not proven beyond that. But it goes into that. It goes into back in 2007, limited research existed with nerve mobilizations. We now know that research is starting to kind of come out. I know we talked about that. We had a great discussion on neural dynamics. But overall, really good article, shows some techniques, just to kind of discussing the history of manual therapy in a short, I think it's 3 or 4 pages? 7 pages of words. So just a really good one to kind of get you going if you're kind of curious about kind of how manual therapy came to be, without going. I mean, I've read articles and blogs that go into 10, 20, 30 pages. It gets a little bit lengthy over time. But yeah, Brandon, do you want to go ahead?
That's great.
What about this?
No, I was just saying thanks for sharing that. That's a great article. I actually haven't seen that one. If you can actually send me that when we're done, that'd be awesome. I kind of want to. That's actually a great segue on what you put, especially that first half, because as you know, and maybe some listeners know, we host courses. They're obviously manual therapy based, especially on the manipulation side. And when we advertise or promote our course, one is coming up. Pretty much every time we get at least one chiro or DO that comments pretty negatively on the fact that, here we go again, a physical therapist is doing manipulation, which they shouldn't be doing. or you're not trained to be doing that, or that's not in your scope of practice, or we invented that, you're taking that from us. One I got was A.T. Still would be rolling over in his grave.
I remember that one.
So A.T. Still was the founder of osteopathic medicine. And we have D.D. Palmer as the founder of orthopedic medicine, or DO, Doctor of Osteopathic. And we have James Cyriax as
Edgar too.
Oh, I'm sorry, what?
There's Edgar too, right?
People I was just going to get to that. Yep. You jumped the gun on me. James Cyriax, which was an orthopedist, right? And we look at him as one of the orthopedic, physician, surgeon, forefathers. Has the contractile tissue if there's a lesion. If it's strong and painful, it's a mild lesion. If it's weak and painless, there's probably complete there. Right? We probably went all over that in PT school. However, his father, Edgar Cyriax, used to be was a physiotherapist in the 1800s, late 1700s, early 1800s. So you could really say that therapy, or any of these manual therapists, therapy disciplines, branch from what was previously physiotherapy or physical therapy, and then has evolved into different branches across history. So with that said, my answer to these people who tend to try and belittle us as a profession, and it really comes down to ignorance and them not knowing the history. This is where I really began to love the history of manual therapy, is while A.T. Still started the first osteopathic school in America in the late 1800s, however, he did not create these techniques. The techniques known as manipulation and mobilization were being performed well prior to him. In Sweden in the early 1800s, physiotherapists such as P.H. Ling, Kellgren, Edgar Cyriax, which is James Cyriax's father, were performing these manual therapy / medicine back then. So it can be said that these techniques originate from physical therapists, which is what I just said. Manual therapy, manual medicine, orthopedic therapy, etc., whatever classification or umbrella you want to put it under, have been developed over time across 4 professions: physical therapists, DOs, DCs, MDs, over the course of hundreds of years. And Jeremy alluded to even back to Hippocrates in the 1500s. You had bone centers in like the 1600s, and basically they didn't really understand the science, and we still don't even understand the science, but literally they were like breaking bones and setting bones, and some people would heal and some had other complications, but they were onto something. Obviously from 1500 we have progressed to now year 2020 and what we do. So it's important to understand that these techniques are shared amongst and across different professions. Obviously, right now we're talking about joint-based manual therapy, but you can talk about dry needling or acupuncture or A-stim versus gua sha, cupping, soft tissue massage, Rolfing, Reiki. I mean, the list goes on. Obviously, our biases, Jeremy and I, is more on the joint-based side. But I mean, you can go across the board here. A technique, it's important to understand, technique is not a profession. And these are techniques that more PTs need to be incorporating, at least here in America. I mean, you go to Australia, New Zealand, these guys, are manipulating day one. But for some reason, there's a hesitancy in physical therapists in the United States. And some of it may be because of training. It may be because they are not confident. It may be because they don't want to offend another profession. But not performing manipulations because you lack confidence or afraid, you're lacking, or you're denying your patients a certain level and quality of care. And if you're not doing it because you're afraid of stepping on someone's toes, another professional's toes, or you feel like it's not in your scope of practice, part of that becomes on you, the clinician, to educate yourself on what your practice act is in the state that you practice in, and not necessarily letting another profession dictate what you can or can't do. So basically, kind of step up your game. In states that no manipulation is allowed, can you do a grade 5 mobilization? Can you do a thrust mobilization? There are great areas around it. I will kind of take a break there, Jer. I don't know if you have anything else before I dive into Cam's lecture he had. I think it's St. Louis, so 2015, 2016. He presented. That's where I got a lot of this information from. So I can't say what I just said is my own thoughts. They are from Cam McDonald specifically. I'm sure he's gotten them from other people along the way as well. So.
Yeah, so I think based off of like what you said, I just want to make really one point of, especially, in America, PTs not either doing manual therapy or not being confident in it. And we kind of discussion an episode was that whether you're a lazy PT or not. And with all these techniques, whatever one you want to talk about, apply, maybe we should go into different styles before you just real quick, who's who, what's what. But, what we know from mostly research and all these sort of things is manual therapy, if anything, you can sum it down, has a great short-term effect. And I won't get into the whole details about how I've had very effective outcomes for individuals with chronic pain that, we're able to get full resolution with the implementation of manual therapy. But, if you can kind of sum it down with a lot of things, it does have, if you're looking at it like longitudinal studies and everything like that, is, the manual therapy groups tend to do better earlier and often, even though I think there's a shoulder subacromial impingement syndrome where people had manual therapy did even better in the long term than those who just did supervised exercises. I'll find the X there, that one. But we talk about, if you're not applying or doing those sort of things, and we have a chronic pain problem in this country, how often are those people becoming chronic pain patients because physical therapy wasn't fast enough in a quick fix society getting some sort of relief or symptom modification or those sort of things? And that's whatever school or tribe you want to go to, obviously, as we discussed before, we definitely we're more biased towards the joint based side of things. And I'd say I'm biased because I'm constantly looking for a better way to improve myself, make myself more efficient. That's why I go through fellowship training and residency training, to be more efficient, to discharge people quicker. Joint-based techniques seem to be more effective for me personally. You can talk about yourself there, Brandon, but we're talking about, manual therapy is, can we prevent getting people into that chronic state, or giving up too quick on manual on exercises or just standard physical therapy? But I just wanted to get that off my chest based off of what you were saying there, Brandon. But I'll, before I guess you get into some things, I guess we can talk about some of the schools or different ones, just in case people are kind of confused about what I'm not going to go into too much depth. But if you haven't heard of Mulligan, I'll just start off like Mulligan is mobilizations with movement. Something I'm a fan with is, their big concept is reposition. Let's say you have a movement, it becomes painful, you reposition the joint so that and then retest that motion as you reposition it. And if it's pain-free, that's you have them move as you're doing it. So their big thing is, I think, PILL, which is pain-free, instant relief, and long-lasting, PILL. So a big one that most people know is the ankle mobilization with movement. You're stabilizing the talus and having have them work into weight-bearing dorsiflexion. There's muscle energy techniques. I think Dr. Fred Mitchell was the father of that. I know Jimmy mentioned Chatau. I know he's a teacher of MET. That's pretty much using muscle contractions, isometric muscle contractions to lead to a lengthening of tight soft tissue. So during that little period where we do an isometric contraction, stimulating those GTO or Golgi tendon organs, we can facilitate the lengthening of some of those tight structures. You're also going to get some decreased edema and a couple other things. Cyriax and Mendel, obviously, we're starting to some obviously manipulation and joint techniques. Cyriax also had a theory of cross friction massage, which is essentially find something and rub the shit out of it. I guess is the most base summed down version of it, and load up with eccentrics. There's a bunch more Calborn theorized the whole concave on convex rule, convex moving in the opposite direction, concave in the same direction when you're doing your joint mobilizations, and Maitland, which has physiological and accessory joint mobilizations, which I think is probably the most common thing. At least I assume most time when I talk to students, most people know the idea of Maitland. Did I miss any there, Brandon?
I mean, I think you at least hammered the original
Big guys.
McKenzie, if you want to call him manual therapy, but I know his is a lot of it's hands off. But there are parts of his program where your hands are on the patient. So I would pretty sure it's Cyriax, Maitland, McKenzie, and Mulligan are like the forefathers. You threw in Clayton Bourne. I mean, he has. I know my PT school entry level training was Clayton Bourne, convex concave. Did not talk about Maitland. I had no idea what the fuck that was until residency. But no, that's a good point you brought up, because there are like 12 different programs that are approved. I think it's 12.
Paris, I forget.
Yeah, I'm not well versed on Paris. I know he was one of the founders of AOMT. I don't know if he has necessarily his own, and I know he has his own school, but I don't know if he has his own quote unquote methodology with it. Or did he learn from Maitland and some other gurus along the way, and then he started his own thing? I could be wrong on that. But I know he's a definitely a mover and a shaker, a leader in the field. Not trying to take any credit from him. I don't think he has like a Maitland approach or something like that. I think, or his own unique one. I think it stems from some other stuff, but I could be wrong. And I'll talk later. But do you have anything else you're going to say?
No. I just wanted to kind of clear up some things about if anybody was just kind of confused on different styles, or they seen a Con Ed course for it. And obviously there's tons of other like people creating their own versions, every week. But they're just creating your own style, and a lot of these individuals, they're all theories. Everything's, theorized and those sort of things. But these people, these forefathers and those sort of things, try and theorize the actual either neurophysiological or the biomechanical components of things versus I'm just going to stretch a certain tissue and call it XYZ. They try and back it up with some theories and a lot of stuff that we base it off of today. Could they all be wrong? Yeah, sure. But at least there's some theory principles behind it. But yeah, Brian, I know you want to talk about what Cam brought up and those sort of things.
I might hold off on what Cam said and the real history, because a lot of the points you brought up, I think it's important to kind of probably wrap up or begin to wrap up this call with, though it might take another 10 minutes or so. Regardless of the technique, I mean, I think too many people, and we had a podcast on this, principles versus methods. And I mean, you and I, obviously with the courses we teach and stuff, we teach a lot of techniques, but it's important to understand the rationale behind it. And I think how you understand the rationale behind it is understanding each person's viewpoint. And then, you probably have to dive in deep to them, down the rabbit hole. And then you have to pull yourself out and look across and see the similarities and see the differences that each, methodology has. And when it comes down to it as the principles, I said this earlier, it's very hard to disentangle all the possible effects that are going on: biomechanical, biopsychosocial, biochemical, placebo, neurophysiological, et cetera, et cetera. And that kind of brings pause. I'll go to that in a second. I want to touch upon soft tissue because there's a lot of courses out there that people spend $500, $700, $1,000 on, $500, $700, $1,000 on, if not more, for these certifications for these soft tissue techniques. And I want people to hopefully start questioning these things. And we can't say a name because we'll probably get in trouble for it. But the technique, soft tissue wise, that you press down with your thumb really hard, and then you move them through a range of motion, and then you release it. And they're not approved for CEUs, and it's because normally to get approved for CEUs, you have to have a 5 or 7 years of evidence supporting it that's in the research, and there's very little on this area. So, ask yourself that. Yet they have the audacity to charge you $1,800 or $2,000 per course, and then have you maintain it yearly, and the year or every 2 years, I don't even know, to then maintain the certification by your names. I mean, that's such a money grab. If you can't see the forest through the trees on that one, and is that any more effective than anything else? I don't know. I don't think it is. If not, I think every clinician would take that. And there's, different versions or different things out there. I'm not saying we can't do those techniques, but I want people to understand, don't jump down at, this rabbit hole and not be able to see the forest through the trees. I think the one thing that I really loved about the Temple's residency and even Regis's fellowship, and just kind of, what I've learned along the way, is it taught a variety of manual therapy techniques. We discussed a lot of different theories, or a lot of what's out there, basically to give you the tools in the toolbox, but to also understand, maybe one person might respond to manipulation, someone else is going to respond to immobilization, somebody else might like a Mulligan mode with movement. We need to be able to ebb and flow within that. If that makes sense.
Yeah, I agree. And I remember my mentor, Tom Michaels, he always talked about tribes and, people sticking to one tribe. And he would essentially, he was knocking on that. And he's just like, even there's a biomechanical tribe, there's this, soft tissue tribe, there's even an evidence-based tribe. He was even saying that has its flaws, and you need to be diverse, and you need to understand. He always said the driver. That was always his big thing. Tom Michaels always said the driver. It's like you need to figure out the driver first. He's just like, you can do whatever the hell you want, but figure out that driver, figure out what's causing things, and then who cares what tribe you're in. So I think I appreciate that about Temple. I know my fellowship, they will do mobilizations, and then we'll do manipulations, then we'll do mobilizations with movements, and then we'll do even METs, all in one course, just in each area. So that's 4 different tribes. It's just like, this may work for one person, and this may not work for another. And it's understanding there is no true homogeneous study, and there's no there's just no homogeneous study ever. You can try as much as you want, and that's the problem with, especially research, is we're trying to apply a fixed, especially interventions. It's one thing about your differential diagnosing sort of things and try and figure out what clusters can identify what group of something. But especially in an intervention case, trying to in these intervention studies is all right. We have to stick to this protocol of certain interventions tested against this exact specific protocol of certain interventions and apply it to a homogeneous study, which even with if you took identical twins and just had an identical twin study case, they're still not homogeneous. Environmental factors, all these sort of things changes each and individual person, and you got to take respect to their cognitive, their emotional state, all these sort of things. And that's why maybe one technique can be effective for another person, why just exercise may be the way to go for someone else versus a ton of hands-on may be necessary for the other, or high education, or a blend of all. So yeah, just kind of take that into account. I don't know how I got into that tangent, but Brandon, I know you were just about to put up something, so let's transition to that.
No worries, all good stuff, man. This lecture, or I shouldn't say teaching. We just had a course this weekend. This topic definitely has tentacles, man. This is a PowerPoint, and I mentioned this earlier today. A lecture, and I was actually, when prepping for this, I was like, wow, I remember sitting in on this a few years back, and it was like, it definitely made you question things and take a step back on some beliefs. And I think at that time I was maybe 2 or 3 years out, had my OCS. I think maybe I just had my SES or was prepping for it, right? So double board certified, think I knew what I was doing. I think I knew everything about physical therapy or close to it. And Paul, who's always very good at making you become real reflective in your approach and what we're doing. He was the keynote this year, and one of his talks was this: the manual therapy world is no longer flat. Obviously, once upon a time, we learned this in history that we all thought that the earth was flat. And then we found out it wasn't, though Kyrie Irving still thinks it is. Dating back to 200 BC to the 1980s, we probably had this more biomechanical point of view. I think, Jerry, you'll like this. We have I can't even talk. Manel, Syriax, Greaves, Maitland, Clayton-Bourne, however you say his name, Mackenzie, Mulligan. That was like all big manual therapy tribes. Then over time that piggybacked and became more pain sciencey, which I think this is great. LV, Butler, Gifford, Butler, Mosley, and Joe Niche. You could probably put Adrian Lowe in there as well too now, as well as maybe some others. And then we have some neurodynamics, Butler as well there. So manual therapy begins to branch out. And I think this is good because a lot of people think pain science is not manual therapy, but obviously we've talked about that it is. So hopefully people seeing this and might help them change their viewpoint. This whole PowerPoint kind of goes over the shift that we need to make. And our profession is huge on this, sadly. We tend to bounce to the newest flavor. That pendulum swings hard one way and swings back the other way. And I think clinicians need to really do a better job of kind of staying grounded and being able to see the forest through the trees on certain things, and maybe stand more in the middle ground. Unfortunately, when it comes to advertising and marketing, middle ground does not sell. Having a right wing or left wing stance is in making some outrageous claim gets you traction, and gets people to comment whether it's for or against you. So I guess from a marketing standpoint, that works. But when you're trying to treat somebody, saying what's in vogue or doing what's in vogue isn't always the best thing there. What was it? Chad Cook talks about, he goes to a manual therapy. Did I pass that? I hope not. Goes to a manual therapy conference and stumbled upon a pain science conference. And that's, just to give you an idea, AMP for a while really swung into, patient education and pain science and things. And As a whole, going to a manual therapy conference, it was hard for clinicians to really swallow that pill. We have hallmark studies such as the CPR, the low back CPR for manipulation. We have the neck CPR for manipulation, shoulder pain CPR for manipulation, that are maybe now being proven as maybe it's not so much those factors, but we need to be able to take a step back. Here we go. Here's the quote I was talking about. But I think it's important, no matter what manual therapy paradigm, it doesn't try not to fall too far into it, and be able to understand when you're going to use one technique over another. And it's really that clinical decision making. But I think the way we are by clinicians and what we like to do, we like that shiny new toy. You and I and other basically manual therapists, we wanted to learn all the techniques in the world. Now, being seasoned vets and having the training that we have, we know it's not necessarily the technique. We probably use the same 5 or 10 techniques all the time. But knowing all the other ones are good to know if that patient needs that one-off technique that isn't, at the top of our toolbox. It's good to know those. And I think our rationale pivots or comes from learning all these different elements. Then you learn how to use things. Can we expedite clinicians' learning curve by saying, okay, begin, doing the basics real well, or begin with this approach instead of, it seems like all the manual therapists, and I shouldn't even say that, all the highly skilled therapists, want to learn everything. And by doing that, they then at the back end learn the clinical decision making. So maybe it just might be a part of the trade type of deal. But I think that this is big, that understanding that manual therapy doesn't define us. It's a tool, and we have to learn which one to use it, whether it's, one of the 7 that, or 4 or 5 that Jeremy talked about, or if we're talking soft tissue, and then some of the other concepts, whether it's nociceptive, or central mediated, or pain science, central sensitization, what else is going on at the level at hand. So I guess we'll kind of wrap up today's podcast, unless Jerry, you have anything else to add in there. But yeah, this is a great PowerPoint. I need to probably brush up on even more, because
I don't think I have that one. If you could, I'll trade you one article for a presentation there. But I was like reading it through I was like, this is good.
Yeah.
But now I totally agree with the whole toolbox, and it's a tool concept. Even at one of my last courses or fellowship weekends, we were just learning a ton of techniques. And even to me at that point, it was just like, whoa, I was just like, I think it was Ben Volkman was the PT teaching it. I was just like, do you use all these in your practice? He's like, no. He's like, you can come out of this course using maybe 4 or 5 new ones, but you keep this manual in here, or it's in the back of your mind one day, and things aren't working out for the client or something like that, and you're just like, let me relook this one up and give it a shot, and something in your brain tells you, hey, that might be the winner. Some algorithms going back there or something of that nature. So I was like, all right, I respected that, and I agree with him. You do, in any course it's like that, but and that goes for anything. I know, even like modalities, since that sort of stuff. I don't really use modalities. I even had like a 2-year streak going without having to use modalities in my clinic. So either ice, heat, stem, ultrasound. I used NMES. I didn't really count that, for some ACLs and that sort of stuff, but iStem or eStem and that sort of stuff. But there's been times where, I had a client, it was a shoulder client, I was doing all the right things, and he mentioned something about eStem the first time. I was like, yeah, we'll get to that. And he had ups and downs, and I don't know if he mentioned it again or I decided to apply it weeks down the road. And that was the kicker. That was really, it stopped the up and down roller coaster effect that he had. Fucking eStem, of all things. I know Scott Burns mentioned a guy about doing ultrasound to someone's back. A guy was sold on it. He kept saying that he was getting better, but he kept talking about ultrasound. So Scott just did it, and the guy was cured, and he's by the next session. So yeah, right. So if you didn't have that in your toolbox, if you not turn the damn thing on, or you just threw it out, it's just you wouldn't gotten that person better quicker. Obviously, as we say, is invest in your differential diagnosing, and some skilled therapists can, especially in regards to modalities. That's why I don't use it as much, is you can kind of negotiate your way out of it and still be effective. But sometimes what's the hurt of ultrasounding someone once and they're fully cured? Does that really result in dependency? Probably not. So just some things in regards to that kind of off-related topic. But yeah, I think it's a good thing to wrap up on there.
Actually, you mind if I say something else?
Go ahead. I got a little bit of beer left.
And we just had a course too, and our course we did extremity manipulations, upper and lower, and we probably taught, I don't know, Jerry, what do you say, 20 plus techniques, including variations.
Yeah.
Right. Variations for people with small hands, outsized therapists, whatever. And just as we're doing this this podcast, and we're talking back and forth, I think some of the learning curve that makes clinicians as good as they are, especially the top tier ones, and no insult to anybody practicing, because if you're practicing and you're trying to get better, you are getting better. Some of it is just, it takes time, and this is kind of me reflecting. You have to go down these different roads or bunny holes, bunny trails, where you're learning all of Maitland's philosophy, all of Cyriax's philosophy, all of Adrian Lowe's philosophy, all of Clayton Borg's philosophy, all of ASTEM philosophy, all of dry needling philosophy, whatever the case may be. NMES philosophy, what are the mechanisms at play? What do we think's going on? Because it's the quest for knowledge and learning all these different things that then gives you the clinical decision-making skill that will make you successful. Because you've probably tried one technique, you've tried another technique, you've understood through and through, okay, I need to do some of the basics well over and over again. A lot of these, good courses will harp on the basics. But I don't think you could just, when you come out of PT school, you're given the basics, but you're not a good clinician. And I guess I use the term good in, relatively, right? But that evolves. The more you learn, the more you try, the more you see. So I just think there's an inherent learning curve, and it stems from trying to learn as many things as possible. But I think it's important to be able to take a step back and not tie yourself necessarily to one thing. I don't know, just something that kind of popped in my head there at the end, and also getting some feedback with the course that we had, and just kind of the more and more we teach, just kind of some thoughts in my head that I decided to pick vomit out for everybody. Yeah.
No, it's good. I agree with that, and I can kind of go off more on it. And I don't. If you're coming out of PT school thinking you say it's relative, and you're thinking, are you good or you're good enough? I think you seriously need almost a reality check, in a sense. Is you're never quite good enough, and there's still things I get frustrated about because I'm not good enough with my clients. Or everybody's got a tricky client. I'm like, why can't I figure this out quicker? Or why is it taking this long? Or why did I take an extra session? Or why did I do this and they didn't respond as well to it? So you should always kind of think you're never quite good enough, especially from the student level. Not to knock you or anything like that. I just kind of think that's the mentality that we should have, and should never quite settle. In this, as long as you're practicing, I think you should never quite settle. That's just me. But before I go too much down that road, but Yeah, I think that's a good way to wrap up part one of this manual therapy history discussion. And yeah, I thought it was a good one. And thanks for listening in, everyone. And if you have any comments or questions or opinions, we welcome them. We're at Nips and Sips on all the major social media platforms. Feel free to subscribe to us. Probably be easier as even though we're pretty in the middle with things, we do get kicked off of some social media sort of stuff. So can't post it to everything. So feel free to subscribe to us. So you know when we're dropping an episode. And yeah, I'm at the Decent Doctor at Trifecta Therapeutics, and Brandon's at Think Like a Fellow and at Pursue PT now. Yeah, Brandon, any last remarks?
Yeah, I guess wrap up. I know this episode will probably hit in a couple weeks, but we are having a lumbo-pelvic course and Jeremy's clinic in the end of October, the 24th, 25th. Going to be going over thrust and non-thrust manual therapy, neurodynamics, exercise progressions, looking at mechanical low back pain, non-mechanical low back pain, some pain science stuff, directional preference, really how to break up some base classifications and how that has evolved as well. So weekend packed, 2 days there. And then in December, we have the first weekend, I believe that's the 5th, 6th, whatever that Saturday, Sunday is. We have our spinal manip course up at Pursue PT. That's a 2-day course. That one's basically all manipulations, follow-up corrective mobilizations or self-mobilizations to kind of couple and pair with the spinal manips. So that's always has been probably our best selling course to this day, always reaching double digits. So look out for that, guys. We also have our video membership, which has over 100 manual therapy videos now. We just uploaded about 20 something from the course this past weekend. We have our mentorship program going as well, going strong. And actually, we have a call tonight as well on Tuesdays and Thursdays. So if you guys have been thinking about it, reach out to us. We'll be happy to take you through a tour, show you what it's about, answer any questions. And hopefully we'll see you guys either at one of our courses or sign up in the mentorship in the future.
Very awesome. All right, cool, everyone. Thanks for listening in, and cheers, everybody.
Good.
Shoot.